And thank you all for joining us for today's webinar on refugee mental health with Ms. Melissa Fogg. My name is Arya Karki, and I'm a program officer at ECDC and also the lead on health and mental health. Please take note that today's webinar will be listen-only mode. At the end of the presentation, we will have about 10 to 15 minutes for questions and answers. To ask questions, please use the chat function on the GoToWebinar control panel, which is on the right-hand side of your screen. Please feel free to ask your questions throughout the webinar using the chat function, and we'll get to them during the Q&A session. We are recording the webinar, so it'll be available on ECDC's YouTube page for future viewing. At the beginning of fiscal year 2015, ECDC sent out a health assessment survey to all its affiliates to find out what type of training would be beneficial to resettlement staff. Based on the response we got, it was evident that most of the resettlement staff would benefit from trainings focused on refugee mental health. Identifying and addressing mental illness in refugees continues to be a challenge for many service providers. Keeping the issue in mind, ECDC has invited Ms. Fogg to provide a training on refugee mental health. Ms. Fogg works as an immigrant mental health specialist at the Philadelphia Refugee Mental Health Collaborative, a wellness-based mental health program she cultivated to meet the unique mental health needs of refugees and immigrant communities. She provides technical assistance and trainings to help service providers on best practices related to immigrant and refugee mental health needs. She has a master's in social work from Rutgers University and over 10 years of working experience with refugees and immigrant communities in a variety of capacities through the International Rescue Committee, Lutheran Children and Family Services of Pennsylvania, Amnesty International, and Rutgers University's Center on Violence Against Women. On this webinar, Ms. Fogg will focus on addressing mental health issues with refugees and tools we can use to assess mental health conditions of our clients. So without further ado, I'm going to go over and turn it to Ms. Fogg.
Great. Hi, everyone. Thanks for that great introduction, Arya. I'm really happy to have the opportunity to do this webinar. We have so many people always coming to us and asking about mental health and best ways to reach immigrant and refugee communities. And it really is a tough issue that I think that everyone is struggling with, especially with the diverse groups that we work with. I always joke that every day I can never pick up one language that I'm working with because there's 4 or 5 different languages that come in and different cultures, and they're all so different, and everyone is so unique. So, looking at mental health in that context is very, very difficult. As background, I don't know how many people are familiar with Philadelphia and what we're doing here. We've been at a couple of conferences, the Refugee Health Conference and some others recently, and ECDC this year. But our collaborative model that we use in Philadelphia is about 3 or 4 years old. We basically developed it because we were struggling, as everyone else was, in dealing with mental health, and it just kept coming up in so many different contexts. And as a city and as a network of resettlement providers, we just were not prepared with a lot of the things that we were seeing. So in that vein, we first started out using more of a case management focused model, which I'll go into a little bit later, but we just found was not fitting. We were making referrals to providers, but the providers weren't trained, and then the people we were sending would go a few times just to make us happy, but wouldn't follow through with treatment. So we were really left asking, how do we reach these people, that a clinical referral may not be a great fit for? And on the other hand, how do we really increase the capacity of the providers that we can find who may not have any idea about how to work with an immigrant or a refugee or a torture survivor or someone who's had some of the really unique types of trauma that our clients have had, So we revamped, we started a collaborative. We are now a partnership of many, many different sectors, sort of looking at a range of ways that people address their mental health and ways that they look at healing, trying to look at the whole person rather than just a medical model that really focuses on a deficit and an issue that someone's having. So in that vein, you'll hear me referring to partners we have. We work with hospitals in Philadelphia, mental health providers, mental health clinics that offer clinical treatment, art therapists, and community-based organizations, in addition to educational support systems and ESL programs through universities that help meet some of the learning needs of our clients. So that's basically where we are. We're about 3 or 4 years old, and I'm really happy to start to share some of the work we've done and do a little bit of training with you guys. You know, as a start, I'll do an overview of trauma and refugees. The word trauma is very scary, but I hope to break it down and give some very usable, sort of easy to digest information about working with someone who may have had a trauma and maybe coming to you. Questions and screening, some ways that we can work together to identify people and sort of flesh out who may be having more of a difficult time or have had more significant things happen to them. Best practices, and then some examples of successful models that we've used in Philly and some of our partners have used. So as a start, I want to just talk about generally mental health, trauma, stressors, and recovery. Looking at the phases of adjustment, I know that that's something people on this call are extremely familiar with. The sort of bewilderment and excitement of someone as they arrive at the airport and how that goes down the chain and can take a number of different roads with the families we work with. What we usually see, and what anyone who on this call is talking about mental health usually see, people who fall to the right, who seem to get past that arrival and sort of reality phase and really just become overwhelmed and withdrawal, have some mental health problems emerge, really miss their family and sort of in their homeland, and then have some more serious support systems fall apart, homelessness, different alcoholism, drug addiction, things like that kind of come out of that end of adjustment. And what I always want to stress when people see this is that people can go back up and really go to the left and negotiate and become integrated. No one is firmly in other areas. Each area, mental health is such a fluid thing, and there's always a potential for someone to really recover and do well with the right supports. So looking at trauma, just as the definition that we like to use in the City of Philadelphia really uses is from the Substance Abuse and Mental Health Services Administration. I'll refer to them as SAMHSA for the rest of the call. They do wonderful work, and really they've made such strides in trying to get mental health and trauma out of the strictly medical model that focuses on something being wrong with someone. They define a trauma as an event, as number one, a person's experience of an event, the way that really impacts that individual person, and the effects of that event and that trauma on a person's well-being. The way that having something happen to you can impact you the rest of your life, or the ways that you react in certain situations. So with that, we always want to kind of keep in mind that trauma also can be sort of based on long-term deprivation of resources, lack of a safe environment, threats and fears. It might not be one acute event, but it can also be that sort of long-term trauma that a lot of our clients have who are in situations in refugee camps or in unsafe environments. It can have a lot of different components to it. I like to sort of use the example of if I see a car crash or I'm in a car crash and someone else is in a car crash and has that trauma happen, the way that I respond to it could be completely different than the way that someone else may. And that for me, I could become phobic of the area where it happened. I could never want to go to in a car again. I could never want to drive. And then someone else might be completely fine and just move on. So it's a very unique thing, and what you or I may perceive as a trauma is very different from person to person or the client we're working with. So that's just something to really to keep in mind when you have someone coming to you, and to, to help you sort of ramp up your sympathy and understand where they're coming from. That it's just a very unique experience and very, very personal. So trauma-informed care in the context of refugees, really it's just keeping in mind that people we see at the point they come to us have absolutely experienced some sort of trauma. As I mentioned, it could be a prolonged deficit of resources, or it could be an acute thing that happened to them if they're a survivor of torture, or however they interpret it. They're here with a refugee status or seeking asylum, and for that very reason, they have a trauma. So that is something that they're carrying with them in a backpack every day, everywhere they go. That memory and those experiences and the physical and psychological repercussions are with them. Given that experience impacts the way that they will seek and utilize services. If they came from a place where they were taught to be distrustful of people and authority figures, they may not open up to you the way you expect, or really come to get services in the same way. Or on the flip side, they could be extremely dependent on you as a case manager, or really not have the confidence or the skills at that point to kind of become autonomous and independent, as we really hope our clients are. Trauma responses and survivors really, as I mentioned, it's a very individualized personal thing, and so the way that you'll interact with each person is specific to them. And something I always just tell my staff to follow their gut and to kind of see what seems to be working, and that there's no formula, there's no prescription that is a one-size-fits-all that someone that walks into your office, and really to use your knowledge and your sensitivity and your feelings about what would work and what the best way to interact with this person may be. Another issue that comes up is the multiple trauma that happens when someone comes to the United States. What we know when they come is that there is a refugee trauma. There's war, there's violence, deprivation of resources, the death of a loved one. All of those things have happened to them before they walk in our door. And then when they walk in the door and they go to a neighborhood where it's not safe, where there is racism, there is poverty, language barriers, they cannot communicate to anyone, and they're very frustrated, changing neighborhoods, family roles are changing, children are dressing differently, they're on the computer, people don't know what they're doing, they feel very disempowered. That's all a different kind of trauma that gets stacked right up on top of the refugee trauma. So we never know how someone's going to react to having that many traumatic events and that many stressors in their life at one point. And especially within the resettlement period, that's something to watch for, because someone could be doing fine, and usually when they arrive, they're okay, and they're not necessarily dealing with the stuff that's happened before, but it takes a little while, and we'll see things sort of start to pop up, within a couple months, within a year, when they come back into the office with more problems, to know that just the layers and the compounded trauma that keeps happening really can kind of make a powder keg at some times, where people might just fall apart, a little bit down the road. So trauma-informed practice, if anyone is familiar with Judith Herman, she's a fantastic scholar and expert in the area of trauma. This just points to all of the different types of trauma that people may see overseas, and really how we're challenged to connect all of these different fragments and figure out what happened to someone and how we can really help them. So with Judith Herman, who is, again, just an expert, there are fundamental stages of recovery, and these are all outlined in the book that I mentioned at the top, Trauma and Recovery. Basically, this is, more clinical than I think a lot of people have to go, but as case managers, as social workers, as people who are out there in the field, you sometimes find yourself in that role, even though it may not be your title or your training. So learning some of the clinical skills and the way that people look at trauma, or if someone who comes with them with a trauma story, is very useful because, again, I think, all of my staff, no matter what their title, is a therapist at some time to some person. So knowing how to deal with that situation is extremely, extremely important. The first step that she looks at when you're working with someone is establishing safety, identifying their strengths and their coping skills. Looking at how can they function, what are their strengths. A lot of times people will come with a trauma or in a situation where they've been a victim for a long time and not realize the resilience and the power that they have and how far they really have come from some of these things. So flipping the story a little bit and making them identify what they're good at, what their strengths are, helping them gain some power and control over different areas of their life is a part of helping people heal and become a little bit better, hopefully. Establishing safety in your relationship with them and also in the environment, making sure your office is somewhere they feel comfortable, somewhere that reflects the culture, the community. We always keep photos and tapestries and artwork from different countries where our clients are coming from up so they can see some of those markers. Knowing that whatever they tell you is confidential, that there aren't going to be stories leaked out into the community or across the agency. Sometimes people just get worried about that layer of confidentiality and gossip. And just establishing your relationship with them so they know that you're a safe person for them. And with that, sort of taking some time to examine your expectations and what your preconceptions may be and kind of what you're expecting when you go into that session or that meeting with that client. If there's someone you've had a rough time with before, trying to really get past that, think of why they might have been a difficult person and go in there with sort of an open heart and an open mind. Once that is established, and also with that is coping skills, I forgot, which is an extremely important component. Coping skills are just ways that people can deal with some of the symptoms that might come up from a trauma. We know that with post-traumatic stress disorder, people might have flashbacks, they might hyperventilate, they might have heart palpitations, they might be phobic of going to certain places or doing certain activities. So helping them get the skills they need to overcome that. So whether it could be some mindfulness, some deep breathing, keeping a photo of a loved one with them they can look at when they're feeling that things are overwhelming, helping them get over some of those very concrete barriers that are maybe psychological in nature and due to a mental health issue or a trauma, but doing what you can to give them the tools to get past that. So coping skills are extremely important. The second would be to reconstruct the trauma story and discussing memories to reduce their emotional intensity. And with this phase number 2, I cannot say enough that it is something that cannot be pushed. If someone is not willing to disclose, don't make them, they're not ready. It has to be something that is subjective and really something that they are feeling ready to and that views that trusting relationship and they kind of feel like they're ready to take that plunge. But when they are, research and every expert says that the more you discuss a trauma, the more you discuss something negative that's happened to you, the strong emotions that it brings up and all of the feelings and even physical symptoms that it can trigger become blunted, and they eventually reduce the more and more you talk about it. So having people tell their story when they're ready, if they're ready, having them repeat it, get used to saying it so it's not as hard of a thing to do is very important. And in this phase, memories are always emotional, contradictory, and fragmented. Every trauma story, at first it might not make any sense. It might jump. It might not give correct details. Some parts of it might not be true. And that's completely normal. It's really just because of the emotions and the feelings and the way the brain just makes these connections and works when you're going through something that is that much of emergency and that much of a trauma. So just bear with it. Just it might not make sense, but just the fact that someone is getting it out is extremely important and will help them in the long run. The third phase that is, to helping someone really kind of get past something they're going through would be restoring the connections between survivors and their community. And that's what we in our program in Philadelphia really try and focus on. And we think that that's, a bolded, starred, size 72 font point, is that people, if they're in an island, if they're vacant, if they don't have friends, if they don't have family, if they don't have a community, they really can never heal. And having a supportive network that they can go to is one of the most important things. And there's so much value in connecting with people who understand their background, understand their experiences, and also can connect with them where they are now. We do a lot of work with groups. Groups for survivors of torture in Philadelphia are very popular. We have sewing groups for women. We've had some empowerment programs. And just having people come together to sort of connect on where they are and where they have been has been extremely, extremely valuable. So it's not, okay. Next would be recognizing the trauma. As I mentioned before, survivors often avoid speaking about their past, and there's lots of reasons for that. That's something that can be very hard for a therapist or a case manager or someone who is, maybe running a survivor of torture program, for example, and needs that story to get them the services that are available. It's very, very frustrating. There's many reasons, but the two that we see most frequently are that people just are not aware of the treatment options that are available and the support that they can get here in the United States for any symptoms that are physical, psychiatric, pain. We can do a lot. And I think making sure that that's conveyed during a meeting with someone is very, very important. Also, communication and cultural barriers. We did a big project last year kind of looking at communication skills and ways that people can communicate about trauma and PTSD and mental health issues in a better way with the refugees we see, because we just kept hearing on, as a collaborative, we work with, everyone from doctors to artists. And what we kept hearing on one hand is that, people were not disclosing what happened to them in a session with a physician. And the physicians were so scared to ask because they just felt unprepared and they didn't know it was going to come out. And on the other hand, the clients and the community members we work with just were afraid of being rude, and they didn't want to speak out of place, or didn't feel like they had the right words in their language or on language line to convey what had happened to them or what they were feeling. So no one was communicating with each other. There was this great disconnect. And when we probed a little bit deeper, and we kind of found out that the clients we were working with were basically just waiting for someone to ask them. At the point of coming here as a refugee, they've been asked their trauma history and what's happened to them so many times that they're kind of expecting it. And the doctors, on the other hand, just were very scared. So, ask is kind of the big theme with that. People are just waiting, and you'll find the resources to deal with what comes out. I think that one of the biggest fears that the doctors and providers we interviewed had was that someone would just break down and melt down and just become completely unmanageable in their office, in their clinic, if they asked these pointed questions that they needed to ask. And that's never, we've very, very rarely, I don't think ever have had that happen in my experience. So that is a misconception that is very common, and really we found is not true. Another thing to look for with trauma is just physical symptoms, and somatic symptoms is what we'd call something that's a mental health issue that kind of presents as a physical symptom. So many of the physicians we work with, again, have patients coming to them with stomach problems, with heart palpitations, panic attacks, and they're doing tests and spending all of this money and all of these, crazy appointments are just making the person more upset. But really, it's just from PTSD or trauma, and sort of the way that people, especially refugees, may identify something that they're going through is through physical symptoms rather than using emotional vocabulary. The caveat, the little asterisk to that, is that, if someone's coming with physical symptoms, you also, and they've had a trauma or some sort of torture experience, you also want to make sure that it's not coming from that. It's not a residual problem from an injury that happened, from a torture setting or something like that. So that's always a question to ask very specifically. And just as, I always put a lot of photos in. This photo is from an art therapy group we did with Nepali families in response to the earthquake, and they loved it. It's just another example of how kind of ways that you can work with people in a non-traditional way who might need some clinical help in response to a trauma. We had art therapists come, and they had people write letters to Nepal and make prayer flags with wishes for the country and talk about their experiences. And it was very emotional, but very, very, very positive, and I think very valuable in the end. So as a symptoms spectrum, sort of looking at, as I mentioned, there's a wide range of the ways that people will present a mental health issue, ranging from, not so serious to very serious. Feeling sad is, obviously not serious. Trouble sleeping is a physical symptom that we know is usually related to stress and something that's going on in your life that's keeping you up. Worrying all the time is another one. It's very, very common. Anxiety, racing thoughts. You can see we're getting a little bit more serious now. Feeling scared all the time. Feeling helpless and hopeless. Not being able to get out of bed is another very, very common one. Hearing voices and seeing things is, again, very more of a psychiatric issue than others, and something that needs treatment immediately. And thoughts of suicide. The second that anyone mentions suicide or any kind of problem, thoughts of harming themselves or others, that's immediately call 911, get them in somewhere. There's no question that that's a very acute emergency. And mental health screening, sort of moving on to a little bit towards our next section, is the first way to begin to help people identify the symptoms on the spectrum, do a little bit of psychoeducation, and then to promote wellness and look at things that people need to get out of that cycle. And then it kind of goes into the treatment model where, there's something a little bit more serious than in maintenance, which is some more goals. And under all of that, you can keep promoting wellness, keep promoting mental health. So this section really is going to focus on how to ask the questions. And again, it's something that people are really getting nervous about, kind of starting that conversation, as I mentioned, with the doctors that we work with. Compared to the refugees, how the doctors were scared to ask the questions, the refugees were waiting but felt it was impolite to offer or burden someone with too many bad things that have happened to them. So screening and having some tools for that is extremely useful and really, really helpful. So if you're going to look at asking questions for mental health, as I mentioned, mental health is an extremely sensitive topic. I try not to use the word mental health with a client ever. It's scary. It doesn't translate. It implies that someone is crazy. The reactions we get if we use the word mental health versus wellness or making sure what you need to feel okay or some other sort of backdoor vocabulary is extremely different. So, but for our purposes, we can use the word mental health. So considering with each person, knowing that, as I mentioned before, their reaction to trauma is unique and specific to themselves and their situation and their personality, is to look at that person you're with and think, when is the best time to screen for mental health? For some people, they might be fine if you ask the question right away, what's happened to you? How did you get here? What's going on? For other people, it might be a little more sensitive, and you might need to build up some trust with them, or their family might need to just take some more time to be settled. So it might be a month or two down the road to sort of see as things start popping up a little bit more. Use your discretion. Who is the best provider for mental health? And that is something that, I wish I had a book of everyone in the United States who was a great provider and people have good experiences with. Unfortunately, it's far and few what we see. But knowing within your community, is there a place that people have went before where they've been able to get really great treatment if they want clinical services, if they want psychotherapy, if they want medication management? Is there someone who has some international experience or who has taken a specific interest in refugees, or even better yet, might have some language skills, which I know is a hard ask sometimes with some of the languages we work with. But who is the best person? And, with that, the caveat is also, is that a clinical referral, or is it a referral to an ESL class? Is the thing that's really causing someone distress, before the trauma, is it that they feel isolated and they can't speak English, and, they're dead set against going to a clinic and going to a psychiatrist or a psychologist because that means they're crazy? What kind of referral can you make? What provider can you reach out to help them in the meantime with as much, with as far as they're willing to go with services? With that, where is the best place to provide mental health care for these communities? We, in Philadelphia, we have some Arabic speakers in one neighborhood and a therapist who speaks Arabic in another that's an hour and a half away by public transportation. And while that's the best place, that's not the most realistic. That also, applies to what I mentioned above, but perhaps making a referral to an ESL class, to if it's a kid, an after-school program, or something that might meet them sort of in the middle if they're not willing to always go to a clinic. What is a good model for mental health care for disparate refugee populations? And how do we continue to advance provider competencies to meet the unique needs of refugees? That is something I'll talk a little bit more about later. But as I mentioned, we have, I think everywhere it's very difficult to find providers who are skilled in working with immigrants and know everything that they really need to meet their needs. So how do we build that network in whatever city or whatever geographical region we live in? How do we make that network so people can get what they need and also what they deserve? So during your interactions, it's important to be cognizant of a lot of things. This is sort of communication 101, which I think a lot of you know about. Be cognizant of language and translation. What we find with the families we work with is that the mental health vocabulary just downright does not translate. It's the word depression doesn't translate in some languages. Stress is very hard to translate. It's even worse if it's something with, more of a psychiatric issue, hearing voices, this or that, which is another reason why clinical services can sometimes be a very hard handoff to make, just because the language line and what the therapist is trying to ask them is not necessarily going to line up. So use very simplified vocabulary. As I mentioned before, the somatic symptoms, the physical things that people are feeling, relaying what you're trying to say through that, like a racing heart, hard time sleeping, no appetite, too much appetite. Using those sort of descriptors to try and ask about someone's mental health is probably what we've had the best success with. When you're looking at what to hook people into, what services, think about what systems, technologies, means of transportation, cultural norms are new for this individual. That could be something as basic as sending a female to a female provider, for therapy or for even primary care, trying to match people up by gender. Make sure people are comfortable with how to get there. Are they even interested in a clinical referral? will they follow through? Kind of trying to flesh that out, because we have many people who go 2 times, maybe 3 times, and then never go back just because therapy just feels uncomfortable, and it's a kind of a U.S. Western method that is not meeting where they came from and what they know. What are possible triggers for this person? How can I avoid them? Trigger being something that might bring up a PTSD symptom or a panic attack. What are things that might be very sensitive? An example we had is we found a wonderful therapist for a woman who was a survivor of torture, but the therapist could only meet her in the medical clinic. And unfortunately, the survivor of torture had been tortured at some point in a hospital. So sending her to a hospital for therapy and to meet with this woman, even though it would have been a fantastic match, just would have triggered too many feelings and really set her off on the wrong foot. So little things like that, and trying to use your sensitivity and your knowledge about their situation to make sure that you know what to avoid and what might bring something out for them. And what new trauma is this person experiencing? A lot of times our questions will focus on what happened to them overseas, or you'll be looking for therapy for someone who had experiences of torture, but what they're really upset about right now might be their neighborhood, and that there's a lot of crime and gangs in their neighborhood, and they went from one place that's not safe to another that's not safe, and they're really dealing with that right now. So, looking at what new things are kind of being layered on to what happened, and how that impacts your conversation with them and what treatment they want. Mental health screening is another one. That is the RHS 15 is what we usually use in Philadelphia and what's being used nationally. Screening is to kind of do an early check-in usually about levels of distress in refugees when they arrive. It's been a mixed bag trying to get it across in Philadelphia, and I know in a lot of areas, but it's something we really recommend using it. We've tried to promote it with healthcare providers and in hospitals, but sometimes they feel like it's cumbersome or it's not something they can bill for. But it's been used with great success in resettlement as well, and that's the model we're using right now in Philadelphia. It's started to do screening and resettlement. So let's see if it's going to, the RHS 15, so I'm sure a lot of people have heard of. It's from Pathways to Wellness. They are based in Seattle, and they basically, for this screener, took a lot of the most salient and most valuable points from a couple different screening tools and a couple different documents, put them together over a very long, very extensive period of testing and translating and making sure that everything was correct and the most appropriate questions to be asking for new arrival, and developed this. It's 15 questions. It's being used nationally. The important thing is that it's predictive. It is not diagnostic. So someone who comes out positive on this might have a little bit of a harder time, but does not necessarily mean that they necessarily need or want that therapy referral right now. These are the questions on the RHS 15. It's recommended to be used in, not immediately upon arrival, but usually within a couple months to try and get it in. It is for adults. I think it's, I might mess it up. I think it's 13 and older it's been tested on, 13 or 14 and older, so it's not really for use with pediatrics or children. For them, we usually try and just interview parents about changes in behavior and things like bedwetting or more physical symptoms. But for this, if you look at it, it really breaks down a lot of the things into physical symptoms and somatic symptoms, as I mentioned: muscle and joint pain, feeling down, sad, thinking too many thoughts, racing thoughts, feeling helpless, dizzy, shaky, can't sit still, crying easily. And then, interestingly, the distress thermometer at the very end of it is what I know Pathways has found to be the most the most, I think, accurate and the kind of gotten the best results with people is just having them scale, you know, on a 0 to 10, how good or bad do they feel, and using that as a way to ask people if they really need a therapy referral, or if they need a referral to community-based services, or even just to use this to start that conversation about what people have been through, to use it in your resettlement intake, you know, within maybe 1 month, give this to them. Just to kind of start asking those questions and make it really normal, like part of their experience. And this is in the U.S., and this is health and mental health are together, and we talk about these things here. So here's a document, we're starting this conversation, and to make it feel normal. The other great thing is that this is translated into pretty much every language we would ever need. So it can be self-administered. Anyone who is literate in English or in the languages that it's available for download are able to, can just do it even while they're waiting for you in privacy, and then go over it afterwards. Screening for torture is another specific skill and another additional set of questions that usually is not included in a resettlement interview or in you know, an intake. These questions are called the Ison Questions, and they're validated and, you know, really are the two things that are recommended to be asked of people who you might suspect a torture situation. So you would ask, you know, were you ever harmed or threatened by the following: government, police, military, or rebel soldiers? And then if they affirm and they respond that they have, you would just say, some people in your situation have experienced torture. Has that ever happened to you or your family? And these questions are open-ended. They're non-judgmental. They really normalize what happened by saying some people in your situation, letting them know that you've heard these stories before. They're not too shocking. You're not going to freak out and have some sort of bad reaction to what they tell you. And it also gives it also gives them that space too, where if they don't want to tell that story and they're not ready to, they can just say yes, yes. And then if they say yes, that can open doors to them for programs they might be eligible for. So, you know, as I've referred to, there are a lot of barriers to clinical care. That's one of the reasons why we've developed the collaborative model that we use in Philadelphia and taken such a strong stance on doing wellness and prevention and mental health promotion. I also think it's one of the most common things I hear from people I work with, you know, across the country, is that, you know, referrals are very, very difficult to make and really hard to get people to follow through with. So the first would be training of service providers. As I mentioned, making sure you have someone who knows what they're getting into and kind of what's going to come out in that session, and how to work with that person given their religion, their culture, their what's happening in their country right now, who might do a little bit of homework about the language and the socio-political stuff that's happening. You know, finding someone like that is hard, but it's something that can be learned. Language access is another huge problem. I know in Philadelphia, and I'm going to assume elsewhere, people just, you know, even the best clinics don't remember to call in a language line. They don't remember to work with the city's Department of Behavioral Health to line up a translator. With that, you know, as I mentioned, the words do not translate. They might know the person who's on the phone somehow, or be familiar with who they are and not want to tell their story. It's just very, very uncomfortable. Sometimes having that third person there can make people very nervous as well, either if it's telephonically or in person. Cultural beliefs about mental health, going to a therapist will make you label you as crazy. I always joke that, you know, I have many family members who are American born and will not go to a therapist. So I can't even imagine someone who grew up in a jungle and had a very, very, very different experience than even the Americans who don't believe in mental health and therapy, how they would make that transition. So cultural beliefs, Western methods applied to non-Western cultures. Cognitive behavioral therapy might not be the best approach for some people. You know, it's the methods and the way that people are taught to ask questions and lead a session just might not work. And again, sitting on a chair across from someone talking about a war or your family being murdered, it just doesn't match up with people's cultures. Fear of authorities. People may, again, be distrustful of people in power. And if you're working with someone who's undocumented or who has issues with their benefits or with their job, they may be very, very nervous to go in as well and disclose what their situation is. Although on the flip side, we have recently had a lot of people who are up for their citizenship exams and who all of a sudden, were really dying to go to a therapist, and we couldn't figure out what this amazing change in their behavior was and how they suddenly, want to go to clinical therapy and believe in it. And then we realized that there is a letter that someone can get to exempt them from the citizenship exam, and that rumor had made its way around some of the communities in Philadelphia. So just be aware of that as well. That has something we've seen as a motivating factor for seeking services, and was a funny discovery to make. Training the trainer. This quote is from a physician that we interviewed in a needs assessment. What he said is, what I really think would be great is to be able to really understand the various cultures and where they come from. What are their health beliefs? What are their mental health beliefs? And what are the do's and don'ts from that culture? Having cultural trainers would be a great asset. So with that and many other, people saying similar things, we started to just do a lot of outreach and do a lot of training of the trainers and work with people who are the physicians and the therapists and the psychiatrists and the medical students and the, MSW students who are going to a clinical route in our city to, one, start to develop that relationship with them. So maybe they could be someone we could send a client to. Two, to always, when we are, give them some background. And then when we are sending someone anywhere, even if it has to be a random clinic just based on a number of factors or we don't know anyone, to get that therapist on the phone and provide some context, send them over a backgrounder about the client to really advocate that they just take 10 minutes to read about where this person's coming from and understand what they might have been through. So it'll be a little bit better when that person walks in the door and doesn't have to, go down to square one and feel embarrassed or shamed for explaining where their country is and what they're going through and kind of the situation. With that, develop relationships with providers and supportive personnel. Just know, kind of getting those people you can call on the phone and be like, hey, Carl, I have this and this and this. Who do I send it to? Is there anyone at your clinic that might be interested in an Iraqi domestic violence case? Can you just ask around, send some emails? Is there anyone who, rather than going through the kind of blind referral, whoever is like next up on the deck, see if you can get someone who's specifically interested. And it's all relational, and it's all making that relationship with one or two people at a clinic. And then when you're making the referral to the refugee you're working with, if they're nervous about going to a doctor or to a psychiatrist or to that clinical site, making it a warm handoff, say, hey, don't worry, I know Julie at this clinic. She's a wonderful therapist. She's worked with 3 or 4 people from X, Y, and Z countries before. Why don't I go with you or drop you off there? We can talk to Julie together, and then you'll know who she is. So it's that trust that they have in you is then transferred to the provider or the doctor and established. And again, that's all relational, and just taking time to make that network, build that network and build those relationships with the people that you're working with, and to just, find the right people and woo them and train them and keep their number in your cell phone. So the framework that we use in Philadelphia and that we promote again and again and again because we love it is wellness and whole health. And you can notice that from the word wellness and whole health, there is absolutely no mention of mental health or any implication of what's wrong with you, something's wrong with you, what happened to you. It's looking at wellness, and that is, a word that people understand and a word that takes away any stigma and really focuses on positive things that can be added into people's lives rather than Above it is safety needs, love and belonging. Esteem at the tippy top is self-actualization. And this I always like to throw in because, I think that therapists or maybe, an eager student coming who wants to do some of that clinical work and get those stories and that result out of a session with a client is really focusing on the self-actualization and the esteem and these sort of more lofty, more kind of brainy goals that people can have when someone who comes as a new immigrant to the country is still focused on, the bottom two and then the third, so do they have somewhere to sleep? Do they have food? Do they have water? Is their neighborhood safe? Are their kids getting to and from school safely? And then, sort of past that, looking when they start to have some mental health issues and things come up and begin to get isolated, making sure that they have that belonging and that love within their community and within their family. But, most people are still at the point of those kind of bottom rungs where they really are just kind of, focusing on the basic stuff. They need to survive in a new country and learning the language and all of that. So reminding, with training the trainers, as I mentioned before, reminding them that what's going to come out in a session, we might know that they were a prisoner of war or something happened to them, but what's going to come out in a session will probably be the things on the bottom, and that's what they'll want to work on, and to really honor that and let them do that and not push. We have a very, very high level psychiatrist that we work with who is, has awards and is just a stellar academic and practitioner, but he always jokes that he's just, kind of an appointment maker and an advocate for them rather than using all of the clinical skills he has. He just helps them get that appointment, and advocate for a fair assessment for their child's educational needs, or he might end up just calling the housing authority for them and doing these very simple things instead of doing, kind of the higher level work that he's used to, and that's completely appropriate, and he thinks that's completely in his role, and he is the best. So we're so fortunate to have him. General best practices moving on are, nonverbal programs and interventions, looking at things that don't require people to have to speak English, ways to communicate their feelings and their thoughts and their desires in ways that aren't sitting and necessarily having a face-to-face conversation. Uniting communities, people becoming isolated and that community feeling breaking down is, very detrimental to people's health and mental health. Reducing isolation, as a community, normalizing people's experiences and having folks talk about them together as community issues, and this could be, a political situation at home, a natural disaster that's happening at home. There's just a flood in Burma that was very upsetting for people, or the earthquake in Nepal that was very upsetting for some people. Talking about that as a recent community issue, and then also things stemming from that about home that they're still worried about, or looking at things that are acute and happening right now, like school enrollment or benefits or citizenship tests, that these are things that people are all very, very stressed out and very worried about, but stressed out and worried together, and that they're all going through it as a group. And teaching and using empowerment methods, trying to make people take ownership over their work, over their just their being and the way they operate in the world, and giving them that little push when they need it, and then celebrating that success. So the wellness framework that I'm about to reveal is fabulous. It's what the City of Philadelphia is really pushing for families. It's holistic. It allows us to meet people where they are. It's great. And these are the 8 dimensions. And the idea of this is that if there is any component of this that is out of whack, of course you're going to have poor mental health outcomes. Of course you're going to be upset. So, if you are, a new refugee and you cannot connect to the mosque that you want, and you cannot practice your religion, of course you're going to feel depressed. Of course you're going to have a very hard time. And looking at these different components of things that make people well, and helping them all be in balance, and presenting it as this way to families you're working with is truly wonderful. And it really, again, takes away that stigma and takes away that kind of traditional medical model of mental health that says there's something wrong with you and that there's a deficit and you're less than something because you're having these feelings. And to that, as we work with immigrants and refugees, we add cultural wellness, which is, gives people support. I think cultural preservation and loss of people's culture is one of the biggest things that people say that they're depressed about. It's not the trauma overseas right now. It's the fact that they can't get the right food. They can't have Karen New Year in a place where everyone can get together easily. They need a spot to practice their dance that they always had. Someone who was a weaver or a chef doesn't have an outlet for that right now. And how do you bridge those things from home that people miss tremendously and put them in with their new identity as an American? And having so many conversations about those changes is very important and very, very beneficial. And really, so much comes out of that about mental health and what people need to feel happy and well in the U.S. So by promoting wellness, it's really, again, it's reducing the stigma and the shame. It's normalizing. Everyone has all of those components in the circle in their lives. At times, all of them can be out of whack, but what can we do to get them back together and on track? It can also bridge towards formal treatment. We have a lot of people who, outright refuse clinical treatment, as I've mentioned. But by starting these conversations about what people need, what makes them feel sad, what makes them feel happy, what things, what hobbies or traditions can they carry on or begin that will help them feel better. Those conversations can help you make that referral later if this problem exists and if there's something that doesn't seem to be caught by community and by some of the prevention work that you're doing. It also builds capacity within communities and helps them self-organize, which is a huge, huge help and a very protective factor. And we know it makes all of our jobs easy in the end, easier when people come together. So really using these conversations and community meetings to help, bring everyone together. One of the most important things that we talk about is just to create a welcoming and a safe environment. Taking the time to listen, trying to not rush people, see what comes out, and looking at the resilience and the strengths in people, their individual attributes, their histories, their families, their cultures, their skills, and honoring that newcomer's drive, and creating an environment where they're free to express all of that. And that can be done in an office. It can be done, take a space in a church basement. Make a space for families and you can meet where it feels positive and it feels good. So if you're going to do any cultural programming and sort of things that look at cultural inheritance and bringing people things from home that they miss, which is, again, our favorite thing to do and what people really love and respond well to, there's a lot of considerations and questions to make sure you're on the mark. And, with all of this programming and community-based programming that I'm discussing, it's always rapid cycle testing and being able to be very flexible if something's not working and figuring out what people want. It's all about responding to the community needs and shifting when things go off track. So maybe talking to the community leader in a community meeting. What are your cultural assets? What are things your community is bringing to the U.S. that you love, that make you feel really good, that make you happy, that or on the flip side, what do you miss? What do you want to learn? Are there things you want to learn in the U.S. that you're curious about in a positive way? Is it baking a pie? Is it learning about, how to take a book out from the library, or, what some of these foods are that people are eating and how to grow them? What are things you're curious about? And kind of enriching that intellectual side, and then people express that. What do you want to share? That goes with cultural assets, sort of what are things from home that you think Americans would love and that you really want to show off? Who are the cultural ambassadors? Who are the people that have these skills that can bring them, who is the master weaver, who is the master chef, who can kind of lead some of these community activities from someone within to sort of create that infrastructure inside a community? And how can we as an agency, as a resettlement organization, as a social worker, how can we help you? What tools can we give you to help you do this and to sort of begin to create these this rumbling within your community that can reach some of the people who feel really lost right now. Community leaders are, as we know, probably one of the most important things, and they inform everything in addition to translating in a lot of cases. And most importantly is to listen, and that all of these questions you're asking might need to be rerouted. Sometimes what we found is that it's really hard to get people kind of off of the we need a job, we need this is what we need training in this. And while that's valuable, yes, we want to hear about the softer things. And so rerouting your questions to sort of ask about those softer kind of mental health things that bring warmth and happiness into people. It's going to take a little bit of different types of questions, but it's really worth it in the end because people are so happy to talk about it because no one's asked them before by and large. So it takes a minute for them to for it to click a lot of times and realize that you actually want to learn about these kind of softer community-based things that they did at home and they really miss. Nonverbal interventions is just, these are some quick pictures of things we've done in Philadelphia to wrap up. We've had exhibits at museums. The woman on the left is an artist, an architect from Iraq, and she's presented her artwork there and sold it. We've worked with a community arts organization to do a series of big murals reflecting people's migration experiences and what they've been through. And we have a corridor of them actually on a street where a lot of the refugees live in South Philadelphia, and have done that with community meetings. People are very proud in the Karen community of the weaving and the textiles they have. So we've organized community sales, and it helps people learn, a little bit about businesses, and had some sort of, craft fair events where they've been able to get their culture out there and share, and also make a lot of money in the process from some of the events. Photography is another great way where we always recommend people working together. I recommend, after this, if you're interested, looking up Photo Voice. It's basically giving cameras to community members and having them answer a question just with a photograph, and it can be used for advocacy. And we had a big art exhibit in Philadelphia of people's photos and their stories that really was great integration, and letting some of the American people in this, this center city art gallery learn about these new neighbors that they have, and kind of what they're going through. And we were able to get a lot of resources and a lot of support through that. So it's something we love doing, and I know we're short on time, so definitely look it up as a method you can use in your own agency. Photography and storytelling. This is sort of a riff off of Photo Voice that we've done, where for Women's History Month we had women take pictures of things in their life, talk about things that they missed. This woman was just talking about her environment and music and having a jaw harp and how it really meant a lot to her. And again, storytelling, this is sort of from the same project, and a response that a youth we interviewed had about that, talking about when they draw, how they feel and how people are interested in their story, and how empowering it was to feel that people are interested in their stories. And these are just some questions for you as we wrap up, things to consider. How are you promoting mental health among your clients, among caseworkers in the larger networks? How can you encourage individuals and community wellness for refugee populations? What are other venues or means for mental health promotion? And, what's been most valuable for us as a collaborative is what strategic cross-sector partnerships can you make to help implement programming? As I mentioned, we don't have, I am not an artist, I am not an art therapist, my staff is not, I am not a doctor, my immediate staff is not. But the way we've been able to integrate programming and mental health promotion by bringing in these people with different skills has been incredible, and for most of it, very, very inexpensive or free of charge. And here's my contact information. I know it's time for questions. My email is on there to contact me directly. We're on Facebook. You can see tons of photos and updates of our work there. Totally, check it out. We also have a lot of our partners on there that you can see what they're doing, the arts organizations and the medical organizations. And our website also has a lot more about our model and the wellness model and sort of some different resources such as training videos that we've produced. All right, and I guess questions or anything else while we wrap up.
Thank you, Ms. Fogg, for the great presentation. Just a reminder to everyone, please use the chat function to enter your questions. I received a question regarding, I've also typed it up for you, Ms. Fogg, but I typed it out. It's from Abdul Bakar, and he is asking, how can we bring to light the hidden trauma catalysts that are culturally taboo to discuss, yet affect the daily activities of women? For example, FGM. So
that's a really good question, and it's so hard. It's something, we're always trying to deal with these things that are kind of the hidden things. There's FGM, which I know has not been as much in the communities we've worked with right now in Philadelphia more recently, but I know it's an issue in the past. We have a lot of things that are hidden. There's some very significant domestic violence and child abuse we suspected but not been able to prove in different cases. And it's so delicate because these things are if you bring it up the wrong way, folks just shut down completely. So with that, I always think that it's the relational aspect and being very delicate and normalizing, something like FGM or domestic violence, putting a woman with a woman, if that's the person you're working with, to really have it be someone who's delicate and knows how to approach the subject and has the trust of that person, and letting them disclose when they're ready, but also kind of offering up the resources. If it is FGM comes up, it could be, sort of offering indirectly, I know a wonderful gynecologist who would love, specializes in blank, 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 FGM, talk a little bit more about that. If you think this service could be something you're ever interested in, or if you'd ever like to talk to her, do the warm handoff. Let me call Linda. She is wonderful. I can make an appointment with you right here today. Or do you want to talk about anything with me? Do you think that's appropriate or not? It's hard, and there is no real formula, but I think sort of making sure it's the appropriate person doing the discussion of the trauma, not forcing it, and kind of maybe offering services and normalizing it at the same time.
We have another question. It's from,
okay.
I hope I'm saying thank you for the answer though, but I hope I'm saying it right. Habtumwa Asore. Can you cite some pointers where you can say the individual is ready to talk?
Yeah, I think there's been again, it's so individualized. Sometimes we've had people where they just get triggered by something and all of a sudden it just all piles out at once. And it happened with a woman who was in a terrible fire that was in one of the camps in Nepal. And she was just kind of, we were asking her very simple questions about her story, tell us a little bit about your life overseas. And it just, and we had known her for a number of years, and this just came out and caught us completely off guard. So sometimes it just comes out and you kind of have to try and keep your face neutral and deal with it as, you can't predict it. I think if someone is ready to talk, there's hints that people might drop. They might start testing you to see if how you respond. And, I think one of the best things is just a neutral face and smiling warmly, and if they're saying things that might hint that something is going on, like many people in my community use drugs. Do you happen to know about where to go for help? And then you can, offer a little bit of information, probe for some more, see if they offer a little bit more. I think sometimes people will test and sort of see how you're going to respond, and also might do it talking about a friend or talking about a family member, community member, when the story is really about them, and just letting them know that you're there and you're offering your support, keeping a warm, neutral face, nodding your head, open body language, looking at them and not the interpreter, those sort of communication cues to send back to them if they're sending them out to you. So hopefully it shows that it's the right time and lets them kind of go forward with those hints they might be dropping.
Thank you. Another question from the same person. For RHS 15 screening, can anyone with no clinical background be able to use the screener form?
Oh yeah, absolutely. If you look at the questions, it's not diagnostic. You're not going to come out with anything from doing it that is, you saying, oh, this person is dissociating and has, some sort of bipolar personality disorder. The great thing is that it's really just questions about symptoms. It's asking if you're sleeping, are you anxious, are you having these sort of, somatic physical symptoms, on a scale of 1 to 10, how well are you doing? There's nothing really clinical per se, like in a formal way that's being asked. It's great. We're trying to just encourage people to use it all over the place, because if anything, it can start that conversation. And just, here's your intake paperwork, here's this other thing, we always do it for everyone. Answer your questions. There might be programs you're interested in. And if you're interested in using it at your agency or even have any questions about it, Sasha Veriskulp at Based Wellness who helped write it, is extremely accessible and really, really open to helping people, and loves to sort of, she could do a phone training, talk to you about any questions you have, sort of how they've used it, where they've seen it implemented. I recommend reaching out to them. They're great, and again, super, super easy to contact, and love talking to people who are using the tool. But no, absolutely no clinical background needed.
It's 4:15, so it's time. So I would just like to thank Ms. Fogg for your time, and I would also like to thank all the attendees for participating. I hope you found the webinar helpful. There will be a brief survey after the webinar, so please take a few minutes to complete it. And if you have more questions, you can always email me, or maybe you can email Ms. Fogg directly and ask the questions, if that's okay, Ms. Fogg.
Yeah, definitely.
All right. Thank you, everyone. Thank you, Ms. Fogg.
Thank you so much.
Bye.
Bye.